Welcome to this session of glaucoma case series. So we have Dr. Ravindra as our chairperson and Dr. Vanita as our co-chairperson and Dr. Lippi as our co-convener. So I welcome all here to the podium. Now I request all speakers to restrict their time to 4 minutes only so that we finish in time. I request Dr. Lippi to take over and proceed the proceedings.
Excuse me? Can we keep the noise down, please? Can we keep the noise down?
Yeah, so it's this was supposed to start at 4:30. I think the presenters, we don't have all. There are about 14 presenters in here. So I'll be just taking the names randomly, and those who are present kindly come to the dais and start their presentations. Randomly means in the serial order which is mentioned in the program book. So first is Ankur Singh. Dr. Ankur Singh is here. Yeah, so please come. Kindly note that your presentation will be of 4 minutes.
Good evening all. Thank you for this wonderful opportunity. I would like to thank AIOS at the offset. So I'm going to talk about a case of, I'm going to unravel the enigma of lens-induced glaucoma resembling endophthalmitis. This is a case of a patient, 78-year-old male, who presented to us with a history of diminution of vision for last 2 years in left eye, with an acute onset progressive painful worsening of vision for 2 weeks. He had no history of ocular trauma or any other ocular surgery, although the patient had a history of pulmonary TB and is on ATT for last 6 months. On clinical examination, the patient has a visual acuity of hand movement close to face, IOP of 40 mm of Hg. Diffuse circumcorneal congestion was present with boggy iris and fibrin. Patient had exudative-like material in the anterior chamber inferiorly, which could be hypopyon or pseudohypopyon. On posterior segment examination, patient just had a yellow glow. We did an ultrasound for this patient and we found multiple pinpoint echo with mild echogenicity throughout the vitreous cavity. However, patient had a normal retinochoroidal thickness. So based on the history, the clinical diagnosis and ultrasonography, 2 diagnoses came to our mind. One is phacolytic glaucoma or the lens-induced glaucoma. Second was endogenous endophthalmitis. So we ordered a UBM for this patient to look at the lenticular status, and what we found was an hyperechoic material in the anterior and the posterior chamber inferiorly with partially absorbed lens and liquefied cortex. And liquefied cortex was seen on UBM as largely echo-free space between the two dotted and a solid line with few echoes. So we revised our working diagnosis to a phacolytic glaucoma. The patient was put on IV mannitol, glycerol, oral acetazolamide, and topical timolol maleate. For the anti-inflammation, we gave the patient prednisolone acetate topically, topical cycloplegics, as well as oral prednisolone. We planned for the patient for 23 gauge PPV with lensectomy, as well as for the cultures. Intraoperative course revealed that this exudate was fluffy in nature and as well as blood tinged. There was partially absorbed lens inferiorly. There were fluffy cortical matter seen in the vitreous with partially absorbed nucleus. In the postoperative period, the patient gained best corrected visual acuity of 6/9 and 14 mm of Hg IOP without any drugs. 9 weeks later, we planned a secondary IOL or 3P secondary IOL in this patient, and patient has a visual acuity of 6/9 partial with IOP 14 without any anti-glaucoma medications. So I would like to conclude is that fluffy deposits with increased IOP is a hallmark of lens phacolytic glaucoma. However, vitreous cells present specifically in the posterior vitreous is suggestive of inflammation like posterior uveitis. Endogenous endophthalmitis usually presents with increased choroidal thickness. In atypical cases, UBM can aid in clinching the diagnosis for phacolytic glaucomas. Hemorrhagic pseudohypopyon is a feature of leukemia, lymphoma, and AIDS. So awareness of unconventional presentation of phacolytic glaucoma is pivotal in accurate diagnosis and optimal management. Thank you.
While making a diagnosis of phacolytic glaucoma, you did not mention about the slit lamp examination. What about the AC depth of the case?
So initially, when we examined this patient, I have mentioned that the patient had a normal AC. I have not mentioned that the patient had a normal AC depth, but apart from that, the patient had a yellowish exudate in the. It more looked like an endophthalmitis because there was yellowish glow with multiple AC full of cells-like material. Probably it was a lenticular material that has leaked. We thought it's initially the cells. But because there was a yellowish glow, we thought of endophthalmitis. However, still at that time, we thought this could case because endogenous endophthalmitis has certain other parameters, like the patient had an IV drug abuse or something like that. There was none like this. But because of the yellow glow, at the same time, the posterior vitreous having the cortical, these echogenicities, the mild echogenicity suggestive of exudate. In phacolytic, mostly they are associated with the anterior vitreous cavity. So that is why we kept the differential diagnosis of endophthalmitis as a second differential diagnosis, not the first one.
My point is that if suppose we differentiate between phacomorphic and phacolytic,
the AC is going to be shallow.
AC is to be shallow in the phacomorphic, and this most likely was a pseudo-hypopion type.
Absolutely, sir.
So
Absolutely.
one has to be differentiate between a true hypopion and pseudo-hypopion.
Absolutely, sir. Thank you.
Yeah, so the next we have is Dr. Divya Dangeti. Is she here? Yeah. Severe ocular ischemic syndrome with NVG in a case with Takasio arteritis.
So good evening, everyone. So today I will be presenting on a case of severe ocular ischemic syndrome with neovascular glaucoma in a case with Takasio arteritis. So here is a 32-year-old female hailing from Maharashtra, came with diminution of vision since 6 months. And it was associated with photophobia, redness and watering since 1 month, which is not associated with any other features. Prior to this, she consulted locally for 6 months ago, where she was diagnosed as neovascular glaucoma with baseline intraocular pressures of 24 in the right eye and 26 millimeters of mercury in the left eye, and prescribed on 2 anti-glaucoma medications. But she discontinued after 2 months. And a year ago, in the past, she was consulted for the severe headache at the neurophysician, where they had advised for MRI brain. And it showed old lacunar infarct, but they did not treat it for it. But the patient had recurrent and persistent headaches, so the physicians had advised on antidepressants, but the treatment was discontinued by the patient by self. But patient had no other significant history except that she was treated for the hypertension. On examination, systemically patient is thin-built and undernourished. An ocular examination, both eyes showed mild congestion, mild corneal haze in both eyes with neovasculars on the iris. In the right eye, the pupil was round, regular and sluggishly reacting, and left eye was dilated. So here is the pictures showing of left eye with pupil is dilated and without any medications. It is not a pharmacological dilatation, it's a normal which patient presented to us, which showed mild congestion and new results on the iris. And on intraocular pressures were 8 and 9 noted without any anti-glaucoma medications, and gonoscopy showed cynically closed angles in both eyes. Fundus examination showed new vessels on the disc with narrowed and attenuated vessels in both eyes, where the arteries were faintly seen compared to the veins. And with this, the differentials we had at this point of time were these, but to rule out whether what is the cause for the new vessels, and actually we are dealing, is it a neovascular glaucoma or not. So here we don't have any history of diabetes or no features of retinal vein occlusion or Coats retinopathy. And to rule out ocular ischemic syndrome, we have referred the patient to physician, where she was noted to have recurrent headaches associated with feeble pulses at the upper extremities with normal pulse in the lower limb, and severe myalgias were noted for the patient in the past, with low blood pressure noted in the upper extremities compared to the lower extremities, and carotid bruit, and lungs which were normal, and in blood investigations noted raised platelet count, and CT showed clinically diagnosis of Takayama arthritis, where severe narrowing of the blood vessels of the large arteries were noted. So the final diagnosis of both eyes ocular ischemic syndrome was made with neovascular glaucoma secondary to small vessel involvement in Takayama arthritis. It is actually a chronic granulomatous inflammatory disease which involves large vessels seen commonly in young individuals, more commonly in females. And this attenuation of the blood vessels lead to ischemic of the entire organs in the body, and which will not treated at appropriate time. It can even lead to further severe complications of the individuals. So these are the most uncommonly recognized features which has to be treated at appropriate time, which if not, these features have been diagnosed to be treated at appropriate time. So the management includes ocular pan-retinal photocoagulation and systemically oral steroids. So on follow-up, patient was a little bit better, but she developed cataract over a period of time with normal pressures without any anti-glaucoma medications. So as we know, eye is a window for multiple diseases in the body. So we have to rule out the disease, and appropriate early diagnosis has to be made in the initial phase to prevent severe vascular damage, and has to be treated by immunosuppressants to prevent severe damage of the individual.
Thank you, Divya. Thank you, Divya. That was well presented, and timely reminder that we should not be only looking at the eye, but looking at the body as a whole. But where is the glaucoma?
Yes, that is the actual thing, because the ocular ischemia is so severe that ocular perfusion is so much reduced. The aqueous, there is no raised pressures in this. So this is not actually a neovascular glaucoma, but we have to treat the systemic condition than the eye.
Agreed. But where is the glaucoma?
Yeah.
Pressures are normal.
Yes.
You've not mentioned this. You talked about NVD.
Yes.
But you know, there are no changes in the disc.
Yes.
So has not developed glaucoma yet.
Yet. But
May not develop glaucoma in future either. We don't know.
Yeah, actually, her previous baseline features elsewhere which were diagnosed showed borderline little bit higher pressures, but because of severity of this systemic condition, her blood vessels were narrowed so much, the ischemia is so severe. So because the carotid blood vessels were so narrowed.
How does that affect IOP?
Because of the secretory phenomenon.
Are you convinced?
Okay. Because these vasculitis affect the large vessels, which affects the common carotids. If you show the CT of the
that's okay. That's, you know, that is something we are not contradicting at all.
Yes.
What we are saying is, you said it's a case of NVG.
Yes.
We've not seen glaucoma yet in this.
Yes.
Okay. Thank you.
Thank you.
I want to highlight one point, that once we want to look for the NVI, we should look in an undilated eye.
No, that came as a dilated.
No.
No, that's right, but we should not dilate, I mean to say, we should not dilate the pupil. We should not dilate the pupil to see NVI.
Yes. But this was patient presented with normally dilated pupil.
But in early cases,
Pharmacologically dilated.
yes, I mean to that we should not pharmacologically dilate
Yes.
the pupil to see the NVI.
Yes.
Because it is more pronounced in undilated pupil
Yes.
than in dilated pupil. Next I request Dr. Indu Pawani to, our topic is when it is not glaucoma, decoding the mysterious field defects.
Good evening, everyone.
Today I'll be talking on the topic of when it's not glaucoma, decoding mysterious field defects. We have a case of 67-year-old male, resident of Nacharam Rangareddy. He came with complaints of blurring of vision in right eye since 6 months. And he was elsewhere previously diagnosed as both eyes primary angle closure, and he underwent both eyes NDR peripheral iridotomy, and he was started on both eyes travoprost 0.004% eye drops once a day, and he has no family history of glaucoma and no systemic comorbidities, and the baseline intraocular pressure was not available. This is a diffuse illumination slit lamp image showing patent peripheral iridotomy in the right eye at 10 o'clock and left eye at 2 o'clock. The best corrected visual acuity in the right eye is 20/30 n-night and left eye is 20/25 n6. So intraocular pressure by Goldman applanation tonometry was 18 millimeters of mercury in both eyes, and gonioscopy showed open angles with few goniosynechiae. And the fundus showed medium-sized disc with 0.3 cup disc ratio, healthy neuroretinal rim, and retina was attached. This is the optic disc image of right and left eye with red-free filter. As you can see, there is healthy retinal light fiber layer. But when we did baseline Humphrey visual field, we can see that there is a superior field defect which is repeatable on 10-2, and it was seen persistent on the subsequent fields which we have repeated, both in right eye and left eye. So then we went with OCT glaucoma. It showed a healthy retinal nerve fiber layer, but the macular GCC showed thinning in the inferior temporal area, which is corresponding to the superior field defect. So at this point we were thinking, did we miss anything? Then we went back to the fundus examination again, where we can see that the yellowish areas, stippled areas in the inferior retina, along with some retinal pigment epithelial abnormalities in both eyes. So at this visit we did macular OCT, which showed focal vitreomacular traction along with multiple neurosensory detachments and double layer sign of pachychoroid in the right eye. Left eye also showed pachychoroid with pigment epithelial detachment. So then we did autofluorescence, which showed stippled autofluorescence in the inferior retina in the macular region corresponding to gravitational tract pattern, which is suggestive of chronic central serous chorioretinopathy, and which is confirmed on fundus fluorescent angiography by patchy hyperfluorescence corresponding to that of the field defect. So in the left eye, we see some stippled hyper and hypoautofluorescence in the inferior retina, which is correspond to the superior depressed points in the Humphrey visual field. So we made a diagnosis of both eyes chronic central serous chorioretinopathy with primary angle closure, status post peripheral iridotomy, and the patient was planned for right eye focal micropulse laser and left eye to be observed, as the vision was normal and near vision was normal. At this stage, because the field defects are caused by CSCR and not due to glaucoma, anti-glaucoma medications were stopped and patient was followed up regularly to check for IOP. So I want to conclude that perimetry is a valuable diagnostic tool in glaucoma to quantify field defects and also to monitor their progression, but all visual field defects need not always be glaucomatous. So we often encounter a situation where the structural and function outcomes don't match up. Then we have to look carefully for other causes which are causing the field defect, and retinal pathologies like vascular occlusion, CSCR, retinochoroiditis and RP can also imitate glaucomatous field defects when the fundal findings are clinically indiscernible. And investigations like fundus fluorescent angiography, fundus autofluorescence and OCT come in handy in cases to bring out the actual diagnosis and avoid unnecessary havoc in further management of the patient. Thank you.
Thank you, Dr.
Yes.
Was it related to central scotoma, then a field defect?
Yes.
So, but the fields you have shown are showing an arcade type of field
In
defect.
this case, it was arcuate pattern because there was a gravitational tract pattern in the involving inferior retina as well, along with macula. If it is only in the central macula, it will cause paracentral or central scotoma.
But we can do a 10-2 test then to document the...
We did.
We have done 10-2 also.
Yes. Did you recheck the IOP after stopping the anti-glaucoma medication?
Yes.
Did you redo the visual fields after the patient was treated?
No. Patient has yet to come for follow-up. We have done focal micropulse laser.
Yeah. So you need to
We have to repeat
recheck
it to see
yes.
whether the visual field defect is. Thank you.
Yeah, so as they say that vision is always more important than eyesight, so that's what Dr. Indu I think emphasized, that we should have a broader vision rather than just looking at the picture. Next we have Dr. Sivani Kodali, bilateral MVG in CRAO with antiphospholipid antibody syndrome.
So, good evening, everyone. So, I am Dr. Shivani. So, these are my abbreviations. And coming to the case, a 60 years old female who hailed from Visakhapatnam came to us on 25th July 2022 with chief complaints of right eye pain, blurring of vision, redness, and watering since one day. Who was diagnosed elsewhere outside as right eye CRAO and was started on Timolate Maliate and was advised systemic investigations, but the patient didn't undergo any systemic investigations there. Where family and systemic history is not nil significant. When she came to our OPD, she presented with in the right eye unaided visual acuity CF 1 meters, and there is neovascularization of the iris with pupil mid-dilated and sluggish reaction. And intraocular pressure in the right eye is 40 millimeters of mercury, and when gonio is done after giving IV mannitol, it appears to be open angles, whereas left eye is normal. So on fundus evaluation, we could see that there is macular whitening with cherry red spot and pale optic disc, whereas left eye optic disc is fine. So with these findings, we came to a provisional diagnosis of both eye pseudophakia, right eye central artery occlusion with neovascular glaucoma in opal angle stage. And we augmented agents in the right eye and started on brimonidine and timolate maleate combination along with dorzolamide. And we advised the patient for intraocular Avastin, but the patient denied at that visit. And later, after 2 days, the patient came to our OPD with severe pain, and at that time she underwent right eye TSC-PC with IOA. So after 3 weeks of TSC-PC and IOA, her vision improved to 2400 with intraocular pressure came to 14 in the right eye. So after that, her intraocular pressures came to normal. Again, in January 27, 2023, she came with the similar complaints in the other eye also with unaided distant visual acuity with HM in the left eye with intraocular pressure 34 millimeters of mercury. So this is the right eye fundus photo, and in the left eye again the patient had pale optic disc, macular widening and cherry red spot. So again we started AGMs in the left eye and continued the AGMs in the right eye and did left eye paracentesis and massage and was advised left eye intraocular Avastin. So now we have a doubt what could be the cause for this bilateral sequential CRAO with NVG in this patient. So we advised the patient the systemic investigations where anticardiolipin IgG antibody came to be positive, and we referred the patient to rheumatologist where he started the patient on warfarin hydroxychloroquine. So what is antiphospholipid antibody syndrome? It is a systemic autoimmune disease which can affect both arterial and venous thrombosis, and fetal losses and thrombocytopenia can happen. So it usually affects 15 to 50 years age, and women are more commonly involved. It could be both primary or secondary, where secondary can be involved with SLE. Ocular findings are usually seen in 15 to 88%, and these clinical manifestations can have a wide spectrum, which could be from asymptomatic up to catastrophic ABS characterized by multi-organ failure also. So these are the some of the manifestations of anterior segment. Posterior segment, most commonly it could be associated with venous occlusion, but in this case it is associated with arterial occlusions, and these are some neuro-ophthalmologic things. So this is a very rare case entity. When I went and searched for the literature, I could find only one case report from the Delhi Journal of Ophthalmology where a small child of 15 years old has been involved. So after that, the patient's intraocular pressure is fine, and her vision is also good. So this is so I just wanted to highlight the thing that even in the elder age group also antiphospholipid antibody syndrome can be positive not only in childhood cases.
Thank you. Do you think the problem in the left eye, catastrophic problem in the left eye, could have been prevented?
Could have been prevented, but even if we have advised investigation, patient didn't underwent any of the
Did you advise? Because you did not say you advised.
You
advised.
We advised, but the patient did
not get it done.
Also.
I call upon Dr. Ravindra now. He's going to talk about challenges with scleral patch graft and glaucoma filtration surgery repair.
Thank you. This is mostly a photo essay. We saw this patient in 2021 after the post-COVID era started. Past history of trabeculectomy for angle closure, angle recession glaucoma actually. Now with this type of image, a low IOP, whether it was a trabeculectomy with mitomycin C or whether it was a surgical scleral flap problem, whatever it was, we had to go in for a scleral patch graft, and for some time it reached normal IOP, but what happened is that this fungal ball came in through the wound into the anterior chamber, and vision was decreased, IOP was fluctuating, high and sometimes moderate. Then we had to give intravitreal fluconazole injections, multiple injections had to be given, and these injections had also to be given into the subscleral area, and after multiple injections, vision somewhat improved, but then IOP rise was frequently occurring, rising to 40s and 50s, and the VR surgeons then saw some vitreous haze and advised TPPV and the repetition of the antifungal intravitreal injections. And this is the condition post VR surgery. But then vision rises again, and then we are now, IOP rises again, and then we are now forced to do the tube surgery. This is just 1.5 minutes of the full 40 minutes of the surgery. Some of the steps only highlighted. So finally, the scleral patch graft also is in place, and why does it always occur like this? Yeah. Go to the last slide. And then IOP is currently under control with 3 molecules for the time being, and vision improved, but IOP may rise yet again. So the lessons we learned from this case were that the first decision to take up this scleral patch graft may not have been the right thing, maybe a resuturing of the wound and conjunctival dissection and forwarding of the conjunctiva with suturing may have been sufficient. And if at all scleral patch graft has to be used, lot of care has to be taken, and maybe the soaking of the tissue in betadine has to be for a longer time, and probably those 2 things could have prevented, and it is with the aim of highlighting these points that we are presenting this case.
So this case, when you did that valve surgery you did, sir, after that?
Huh?
Tube surgery you did, no?
It was AGV.
Yeah, so you have followed up for how many months after that, sir?
Yeah, right now it is in 3 months follow.
Okay, so
Yeah.
3 AGMs you have?
Yeah, yeah.
Okay, so that was a non-walled implant, or what was
No,
put?
AGV.
Okay,
Valved implant.
walled implant was
Ahmed
put.
valve.
Okay, I think it was a low-grade end-off
Yes,
which
yes,
happened,
yes,
and,
yes.
okay.
So when did the fungal infection occur? It happened after you put the
After-
first patch graft?
Yes, yes. Almost 8 weeks after the patch graft. We thought that it has improved, and then the fungal infection came, and there was the need for VR intervention.
Thank you, sir. Next presentation is from No Glasses to Bleb by Swani.
Yeah. Once again, good evening all. So my case here is from No Glasses to Bleb. These are my abbreviations. The objectives are what could be the various causes for IOP elevation post-refractive surgeries, preoperative considerations, and management of steroid-induced glaucoma. So my case is of 24 years old male who hails from Vijayanagaram, who came to our OPD on 2nd March 2023, who underwent both eyes PRK elsewhere in the last month, and after which he was started on steroids, for which he developed rise in intraocular pressure, for which he was started on AGMs and was shifted to low potent steroids. So family history, even his mother has high myopia, no family history of glaucoma, systemic history is nil. So on ocular examination, on examination of the right eye, unaided visual acuity is 20/30, and all the both anterior segment is normal, with intraocular pressure in the right eye is 31 millimeters of mercury, and left eye it is 19 millimeters of mercury, with gonio open angles, and CCT post PRK it is 408 and 406 in the left eye, and fundus disc is healthy. With this, we came to the provisional diagnosis of both eyes high myopia, post PRK, and steroid responder. So what could be the various causes for IOP elevation post-refractive surgery? Coming to the first one, PRK, it could be steroid responder or pigment dispersion. Post-LASIK or femtolasic or epilasic or smile, it could be due to intraoperative due to suction, or post-operative could be due to steroid responder, pigment dispersion, and angle closure. Phakic IOS, it could be due to retained viscous steroid responder. It could even lead to angle closure, which could be due to both pupillary and non-pupillary block, and it could be malignant glaucoma. So these are the few photographs which I had post PRK where steroid, where there is IOP elevation. Post smile, due to this the patient was started on steroids, and post ICL there is pigment dispersion in this. So what are the preoperative considerations that we need to take? So we need to check thoroughly intraocular pressure, and the CCT is a must in these conditions because it is very essential for the post-op management, and gonioscopy is very must in each and every individual who is undergoing any refractive surgery, because most of the hypermetropes will have shallow angles, and there could be even pigment dispersion where trabecular meshwork could be even of grade 4, and visual fields needs to be done for the OCT, and optic disc also needs to be done, because optic disc photographs are very essential, because it is very difficult for us to assess the optic disc. Even post-op management also depends upon it. So these are the few others who studied on steroid responders post PRK. So the steroid responders varies from 7 to 12%. Coming to the management, it could be managed both medically and surgically. So how to manage steroid-induced glaucoma? So first, initially we can shift to low-potent steroids or start or augment agents. Even after starting or augmenting agents, if the intraocular pressure is normal, then we can taper steroids and continue agents. If IOP is still high, stop steroids and we can augment agents. Even after that, if the intraocular pressures are high, we can augment agents, either do GAT or trabeculectomy. So we augmented agents and started even on Repatec eye drops, and his pressures are still in elevated state. So we advised trabeculectomy, but the patient denied, and later we did left a trabeculectomy initially. So at 1 week visit, his vision is 20/80 and intraocular pressure is 4. At 1 month it is 20/50 with intraocular pressure 8. So after that we did right eye trabeculectomy where his vision is 20/60 with intraocular pressure 8, and at 1 month it is 20/80 parts with intraocular pressure 9 millimeters of mercury. So after that his intraocular pressure is maintained well. This is the timeline of the picture. So I just wanted to highlight here is preoperative considerations, better to do intraocular pressures, visual fields examinations and gonia and everything, so that it would be easy for us to manage post-operatively.
Thank you once again, but I would like to highlight a few things here. First and foremost, we now have a lot of minimally invasive glaucoma surgery available, which then, you can avoid such blebs in patients who have, probably no visual field change, although you didn't tell us about the visual field change.
Yes.
Yeah, and you see what you're now done is allowed or put the patient at risk, lifetime risk of blebitis and bleb associated endophthalmitis. So one should really avoid, and between trabeculectomy and GAT, as you say, between that also we have many more procedures. So just unroofing the Schlemm's canal 90 degrees with a needle, a bent needle, if there is a problem with the cost, it works very well in steroid-induced glaucoma.
Yes, ma'am. Thank you.
Thank you.
Dr. Sivani, I would like to know, was this a steroid-induced rise in pressure or glaucoma, whatever you're saying? What was the cause?
No, what we thought here is there is no other cause for elevated intraocular pressure, so only after giving steroids only his intraocular pressure is high. Previously it used to be normal.
So probably it is a steroid-induced.
Yeah.
So it was not turning normal even after steroids have been stopped?
After even shifting to low-potent steroids, after stopping steroids also, still his pressures are not under control.
Okay.
The next presentation is by Mahbub Basha Sheikh, GAT Challenges for Beginners. Dr. Basha is here.
Good evening all. On behalf of VST Center for Glaucoma Care, LV Prasad Eye Institute, Hyderabad, myself Dr. SM Basha, glaucoma consultant. I would like to, as everyone knows, as Dr. Vanita was just telling, GAT is trending now, especially the mixed microinvasive glaucoma surgery. I thought of one presenting a intra-op complication, that is ciliary body cleft and its management. A 60-year-old male diagnosed with angle recession glaucoma, post-blunt trauma with significant cataract in the right eye. Baseline IOPs were 40 mm of mercury. Best corrected visual acuity was 20/30. Gonioscopy showing open angles in both the eyes with 360-degree angle recession in the right eye. Optic disc in the right eye showing 0.9 cup disc ratio with broad inferior notch. And left eye was fine except for early cataract changes. He was started on topical anti-glaucoma medications in the right eye. Later in subsequent follow-ups, his IOP was still high. Hence combined surgery was advised. As gonio is open angles, we planned for phaco with IOL with GAT in the right eye. one of our trainee has started the case. First we went ahead with the clear corneal phaco, temporal incision, and then after completion of the phaco, 110 nylon suture was applied, and then this is the introduction of 50 Prolene suture. I have just taken few snapshots of the surgical video so that for better understanding. So this is the main picture here. So after phaco done, so this is how we do the microscope adjustments and then patient head tilt, that we all know. So this is the ultimate picture where GAT will start. So here one should appreciate the angle structures. So usually we found two darker structures. One is the pigmented trabecular meshwork and the other one will be the ciliary body band. As the patient is already known case of angle deficient glaucoma, here the ciliary body band it's very widened and it's irregular widening. What happens in angle deficient glaucoma? So the above line, the darker line is the PTM. Now see here, the goniotomy incision which we do, we are supposed to make the incision at the upper limit of trabecular meshwork, but here we can see the surgeon doing the incision at the upper limit of ciliary body band, because of we know that it's not the normal angle, because it's being a traumatic eye, and also in beginners it happens. So the incision wrongly was given at the upper level of ciliary body band, and then again the surgery was proceeded. And here also we can see whenever the Prolene suture is introduced into the eye, after making the goniotomy incision, the proximal end should be visible. Actually we see when we introduce it into the Schlemm's canal, we can see the proximal end, the tip we can see it is going into the Schlemm's canal. But here we can see absolutely, we can't see, it is completely opaque. One more, it's an indicator of false passage. Then you can see again, while introducing the Prolene suture further, there is more of bleeding also. So when I took over the case, and then I just pulled out the Prolene suture in the reverse direction, and then after keeping the visco cohesive, this is what I can see. This some darker structure which was not there previously, that is what is ciliary body cleft. So usually we see less commonly the CB cleft because we see hardly in post-traumatic eyes, but this is the intraoperative iatrogenic CB cleft. 2 to 3 clock hours I noticed, and then I just abandoned the surgery. And then the post-operatively day 1, the best corrected visual acuity was 20/100 with IOP of 10 mm of mercury. Patient was started on antibiotics, steroids and cycloplegics. As I am very sure the CB cleft was there on table, I started on cycloplegics as well. At 1 week, the best corrected visual acuity was 20/50 with IOP of 15 mm of mercury. Gonioscopy showed nasal ciliary body cleft. UBM on same day confirmed the nasal ciliary body cleft with 360-degree ciliocoroidal effusion. Same medications were continued. This is the UBM picture. I have kept in the clockwise pattern. On the 3 o'clock hour, we can see there is CB cleft, some discontinuity with the ciliocoroidal effusion, and then on 6, 9 and 12, all clock hours showing the ciliocoroidal effusion. Subsequent follow-ups showed slow increase in IOP, and at 1 month visit there was an IOP spike of 40 mm of mercury. So why this happened? As we know, intraoperatively the aqueous is going back. So definitely in the we won't see IOP spikes immediately. So as now we have not done anything glaucoma surgery for the patient. It was an intraoperative complication. We just went ahead with the phaco and then we abandoned the surgery. So this was expected only, which at 1 month we saw IOP spike of 40 mm of mercury. And then on that day, the clinical evaluation and UBM showed resolution of choroidal effusion, stop topical steroids and cycloplegics, and was started on oral and topical anti-glaucoma medications. In the next couple of weeks, the IOP was still high on maximum medical therapy. Subsequently, we planned for trabeculectomy. So this is how we can see at the 1 month post-op. There is no CB cleft, there is no ciliocoroidal effusion at all in all different clock hours. So to conclude here, cycloplegic drugs are the mainstay of medical therapy, which cause relaxation of the ciliary muscle tone and dilatation of the ciliary body ring, and will help to oppose the detached muscle fibers to the sclera. The role of topical steroids is still debatable. Some will tell increase the steroid use, and some will tell to reduce steroid use to promote inflammation and cilioscleral adhesion. So as the angle-based surgeries are on the rise now, Understanding various complications, their identification and management are important for the beginners. Creation of false passage is likely to occur while one starts doing GAT or goniotomy if the incision is too deep or higher or lower. As it was lower in our case, the surgical field should always be clear and visible on gonioscopy lens. After making the trabecular sheath, the passage of Schlem's canal should be visible to confirm the entry of Prolian suture. And also after a certain length of suture has passed, not visualizing the suture in the opposite side canal or noticing unusual iris movement or pupil peaking or patient experiencing pain in spite of local anesthesia or excess bleed while procedure is progressing, all are the signs of suture not in the correct location, and one may need to stop the procedure and relook at what is happening. So one can proceed with the procedure in the opposite direction and complete the surgery. In the event of any complication noted, like how in our case, better to perform a goniotomy if possible or an abundant GAT or manage accordingly based on the response rather than worsening the problem. So as GAT is now increasing now, so I would like to request whoever is doing GAT, please come up with your experiences, and whoever not yet started, yes, you people can start. Yes, I agree, intraoperative, it's not that easy, the learning curve is there, some complications will be there, but how I showed, complications to the great extent we can manage easily. So then wishing all the best for GAT in future. Thank you.
Dr. Basha, I have a question here. I don't have that much experience with GAT, maybe you're better in it. So do we do GAT in such cases, angle recession, glaucoma, goniotomy and GAT? Is it being done abroad or how are the results?
Yes, in open angle glaucomas we are doing. Is it primary or is it secondary? Yes, we are doing, yes, we are having good results and the study is going on. Open angle glaucoma, previously we used to take almost all cases, but nowadays the very advanced glaucoma we are not taking, and what importantly we are looking is the locality of the patient also, from where the patient is coming and how much is his understanding ability to explain about the GAT and the consequences, and patient should be available for the follow-ups as well.
So angle recession glaucoma we can do GAT?
Yes, you can do angle surgeries. In fact, it responds very well to angle surgery. Steroid-induced as she presented, angle recession as he presented. But I just wanted to go back on your slides, and for the sake of the audience, please point out exactly where the trabecular meshwork is. Because you had still photographs. It's extremely important for people to understand the anatomy of the angle before proceeding. It comes up as a red line. Why is it red? Because in the Schlem's canal, that's your trabecular meshwork, the red line. Why is it red? Because you have regurgitation of blood in the Schlem's canal. So that is your trabecular meshwork, and underneath it is the Schlem's canal. So he should have been at that level rather than below. He's gone into the ciliary body. Yeah. Thanks for being honest and presenting this case.
Thank you. Thank you.
Yeah. The next speaker is Prerna Garg, a case of keratoiridolenticular dysgenesis.
Good evening, everyone. So this is a case of actually bilateral congenital corneal opacity. A case of bilateral congenital corneal opacity. A child presented at 10 days of birth with high IOP in both the eyes, along with a diffuse corneal opacity with central clearing present in the right eye. The child also had a ill-defined telangiectatic patch on the forehead, and IOP was high in both eyes. On B scan, both eyes had a normal lens echo. Retina was attached and choroid and optic nerve was shown to be normal. On asking the history, it was a full-term cesarean delivery with normal birth weight, no history of delayed crying or NICU stay. The child was started on a combination of 2 drops twice a day in both eyes and planned for EUA once she attained 4 kg weight. So after a month, EUA was done. IOP was found to be still high on 2 AGMs. The horizontal corneal diameter was 11 mm in both eyes, which is high, which is more than what is expected for her age. Axial length was 23.4 mm in the right eye and 23.7 in the left eye. In the right eye, she had a diffuse paracentral opacification with central 3 mm clearing. Left eye, there was very less clearing in the center. Opacification was similar to the right eye. So left eye trapezius trap was done in the same sitting, and in the right eye, the anti-glaucoma medication was stepped up. On follow-up visits, she was followed up in the OPD because repeat GA was not done, as her IOP was controlled in the left eye, and we could see the bleb in the OPD itself. In the right eye, she had a IOP was controlled on the 3 anti-glaucoma medications till the next 4 months, after which there was one high reading. So repeat EUA with UBM was planned. And in the right eye, we found that the horizontal corneal diameter had increased from 11 mm to 13 mm, and also the axial length had increased by 2 mm. IOP was uncontrolled on 3 AGMs, which was done by eye care. In all the settings, it was done by eye care. Whereas in the left eye, the horizontal corneal diameter and axial length was same. UBM was done in the right eye. There was a central clearing which was seen, so the lens could be seen. There was corneal lenticular adhesions. Corneal lenticular adhesions were present, but the central cornea appeared normal. Whereas in the left eye, there were only corneo irido adhesions, which was seen. There was very little antechamber present, but no corneal lenticular adhesion could be seen. So right eye trapezius trap was done on the same sitting. And so diagnosis of right eye type 2 Peters anomaly and left eye type 1 with both eyes early onset glaucoma was made. Pedigree analysis was done, which was sporadic in onset, and she was referred to a pediatrician for evaluation. That was at 8 months. So she had developmental delay and was counseled for physiotherapy. Also, she was referred to the visual response clinic and advised visual stimulation exercises. The unique findings in our case included the telangiectatic patch, which was like a portwine stain or an hemangioma, which is now it is decreasing in intensity. And also in Peters anomaly, it has been found that characteristically there is a posterior stromal defect which should be present, which was not present in our case. The posterior cornea seemed completely normal in both the eyes. So Peters anomaly can be Peters type 1 or 2. Both can be associated with systemic associations and glaucoma. And coming to the Kenishal classification, he has said that instead of corneal opacity, it should be classified as a keratoiridolenticular dysgenesis, which has different categories. So in our case, the patient had iridocorneal adhesions, with the right eye having maybe corneolenticular adhesions also. UBM is important in these cases to diagnose the anterior segment behind the cornea. And glaucoma affects 50 to 70% cases of Peters anomaly, with the elevated IOP being either from trabecular dysgenesis or angle closure from the iridocorneal and corneolenticular adhesions. And GDDs are supposed to have a higher success rate, but in our case, since the superior conjunctiva was normal, we first thought of doing a trapezius trap in both the cases, and they are working wonderfully. For the last 1 year, we've been following up, although they're supposed to have a less success rate. Thank you.
You mentioned about some telangiectasia on the skin.
Yes, yes.
So is that seen in Peters anomaly? Or
no, it's not been reported as such in literature, a presence of a portwine stain or a hemangioma. So, but it is most probably a hemangioma because it is decreasing in intensity without any treatment. So no treatment was given for it, no propranolol or anything, but it is decreasing in intensity with age. But it has not been reported with Peters.
Okay. Follow-up has been of 3 to 4 months.
1 year now.
Okay, 1 year. And pressures are controlled. Okay, thank you. I think it was Prerna. Thank you, Dr. Prerna. We move on to the next presenter, that is Dr. Tirupati Sayaswant, Management of Malignant Glaucoma After TRAP in Eye Syndrome with Microspherophakia.
Yeah, namaste and good evening everyone. So I want to present today about the malignant glaucoma after trabeculectomy in ICA syndrome. So regarding coming to my case, 19 years old female from Andhra Pradesh, visited at first time in 2019, complaining of both a diminution of vision, which was gradual and progressive in nature since 6 months, associated with pain and redness. There was no any history of trauma or medication usage or systemic diseases. And when coming to the ocular examination, at the time right eye, her visual acuity was 20/100, improving only up to 20/40. And iris conjunctiva was clear, cornea was clear, but anterior chamber was shallow with iris showing the atrophic changes. And when coming to the pupil, it was irregular, sluggishly reacting to light and polychodia. and lens was clear, and we have found microspherophakia and dilatation. And IOP with GAT at 2:54 p.m. it was 34 millimeter of mercury, and on doing the gonioscopy there was a 2 angles closed with goniosynica and peripheral anterior synica was noted. On fundus examination there was a retinal pigment epithelial hyperplasia with bone spicule pigmentation around the superior arcade vessels starting near the disc with a 0.7 cup disc ratio with sloping rims, and central corneal thickness was 540 microns and the axial length was 21.61 mm and specular count was 1700. This is regarding the right eye. And when coming to the left eye, best corrected acuity was the 20/30 and the anterior chamber was shallow with atropic changes, and the pupil was same like right eye, sluggishly reacting and polychoria with microspherophakia and dilatation. And the intraocular pressure was at 28 millimeter of mercury, and one angle was closed and goniosynica was seen. And fundus also same like in the right eye, there was an RPI hyperplasia with bone spicule pigmentation with a 0.7 cup disc ratio. Corneal thickness was 530 microns and axial length was 21.42 and specular count was 1900 cells per mm square. So we came to the diagnosis of both eyes iridocorneal endothelial syndrome, both eyes microspherophakia and both eyes S-cone syndrome. So we started with, as IOP was high, we started with 2 AGMs and we called after 2 weeks, but patient lost to follow up and again came with pressures of 24 and 22, and after 6 months again patient came, so we augmented the AGMs and all the complaints was stressed. Still the patient was unaware of what's happening, although I explained everything, and patient came after 2 years with IOP of 24 and 26. So finally I advised trabeculectomy for both eyes. So after left eye trabeculectomy, intraocular pressures came to 10 plus or minus 2 millimeter of mercury with a moderate height, elevated bleb and doing well. After right eye trabeculectomy, since post-operative day 1, anterior chamber was very shallow with the peripheral lenticular corneal endothelial touch with the intraocular pressures of 11 plus or minus 2. CDL test was negative. I suspected a malignant glaucoma and I started cycloplegics and aqueous suppressants and other post-operative medications were started. After 1 week, as there was no improvement, UBM was done and finally we concluded as in malignant glaucoma, and we planned for pars plana lensectomy and core vitrectomy, and post vitrectomy patient was doing well with intraocular pressures of 12 plus or minus 2 millimeter of the mercury. So when coming to the pathophysiology, although poorly understood the pathophysiology behind it, which is involved an alteration in the anatomical relationship of lens, ciliary body, anterior hyaloid phase and vitreous, which results in forward movement of the iris lens diaphragm. And UBM mainly it helps in both diagnosis and the monitoring the therapeutic response in eyes with malignant glaucoma. It demonstrates the rotation of the ciliary body, marked displacement of structures of anterior segment, peripheral iridocorneal touch, and forward shift of lens may be noted by using the UBM. And B-scan may be used to rule out other causes of flat anterior chamber such as suprachoroidal hemorrhage or choroidal effusions. And OCT may be used as a non-invasive technique for monitoring any anterior chamber narrowing in the affected eyes. So treatment strategies, if we follow, for example in the phakic patient, if we do the cataract extraction with posterior capsulotomy and vitrectomy, and in the pseudophakic or aphakic patients, if we do the Nd:YAG laser capsulotomy and finally the vitrectomy surgery, the outcomes are very good only. The main thing is that we have to never forget the management of the fellow eye. So after an episode of the malignant glaucoma in one eye, there is a high risk of this complication occurring in the fellow eye after a surgical intervention. And patient should be warned of this when consent is taken for surgery on the fellow eye. Prophylactic measures including the cessation of the miotic drops and prolonged use of atropine after the trabeculectomy surgery, and preoperatively prophylactic laser peripheral iridotomy all should be done as a prophylactic measures. And these methods will help maintain the normal anatomical position of iris lens diaphragm and reduce the risk of aqueous misdirection. So I want to conclude that malignant glaucoma continues to provide a therapeutic challenge which probably reflects our limited understanding of its etiology. Whatever the true mechanism, the fact that is relieved when direct communication is made between anterior chamber and vitreous cavity support the theory that lens, anterior vitreous and ciliary process are intimately involved in the pathogenesis. All eyes with primary angle closure glaucoma should be closely followed, particularly in the early postoperative period following the glaucoma dryness surgery. If a patient develops malignant glaucoma in one eye, preventive measures should be taken to prevent occurring in the fellow eye at the time of surgery, and prognosis of this condition is good with currently available treatment modalities. Thank you.
Right, thank you. You are Yashwant,
Yes.
yeah? Okay, we don't know your name here.
Yeah, it's a full name. Yeah.
Okay. So tell me something, how did you diagnose spirophakia?
So on dilatation, there was a journals was not in proper, and there was a gaps will be founding. So
Where? In the zonule?
in the journals.
Is that the only criterion? Did you see the refraction of the patient? What happens in spirophakia? What is the
So-
refraction of the patient?
So it was improving with plus. It was improving.
No, I'm talking about at presentation.
Yeah.
The refraction was not very myopic.
Yes.
Spherophakia has to have a degree of high myopia,
High myopia,
not
yes.
just myopia.
Yes.
So how, I am a little confused how you diagnose.
Okay.
Anyway, that's beside the point. The second point I want to make is, you did a lensectomy with the
Yes.
pars plana vitrectomy.
Yes.
Is it possible to do lens sparing surgery without actually going posteriorly?
Lens sparing, actually it was iris. The lens is.
Or in other words,
yeah.
let me rephrase that. Is it possible to do a cataract, it wasn't cataract, a clear lens extraction and approach the vitreous anterior hyaloid phase is what you want to disrupt
Yes.
anteriorly?
Yes.
Then you could have saved the patient from becoming
So
aphakic.
in that case, actually the lens is almost touching the endothelium. So
Doesn't matter. You use mannitol. I have done many cases. You use mannitol, use cohesive, good quality, cohesive viscoelastic, make space.
Okay.
That is not going to require phaco power.
okay, yes.
It's only going to require lens aspiration.
Aspiration.
So then you could have, aphakia in this day and age is mutilating surgery
Okay.
for a young patient like that.
Yeah.
It can be approached anteriorly. You can do, and you've not given that procedure, iridozonulohyaloidovitrectomy.
Yes.
Can malignant glaucoma, you call it malignant glaucoma, I don't like to call it malignant glaucoma, I call it aqueous misdirection. Can it recur after pars plana vitrectomy?
No, chances are less after pars plana.
What do vitreous VR surgeons do? They do a core vitrectomy.
vitrectomy.
They don't come up to the lens. Of
Lens.
course, they sacrifice the lens here.
Yeah.
So here it won't recur.
Yes.
Okay? But if you don't come up right up to the lens, and I am primarily talking about lens sparing surgery, meaning you take out the crystalline lens and replace it with an implant.
Implant. Okay.
Yeah. Okay? What that patient will now need is a sclerofixated IOL.
Yes.
Okay?
Yes, sure.
Thank you.
Yeah, thank you.
Yashwant, one question. Why was there spicules or something you mentioned in the fundus? Some pigmented spicules you mentioned in the fundus, or did I get it wrong?
Yeah, it's Yes-Cone syndrome was there for that patient.
So it's a feature of that.
Yes, right.
And the hyalotomy can be done. Hyalotomy.
So you can use a retractor, create a PI, then go further down, do a zonulectomy, and then turn your retractor towards the posterior capsule,
Yes.
disrupt the hyaloid phase, and do a primary posterior capsulectomy with the IOL in position. It's possible.
Yes.
Patients do very well.
Thank you very much.
Yes, thank you.
Next presenter is Dr. Prerna Garg. She will speak on bilateral nanophthalmos with unilateral angle closure glaucoma and optic disc fading.
No, the other one. Okay, good evening again. So this is an interesting case of bilateral nanophthalmos who presented to our OPD. So these are the normal findings which we get in a patient of nanophthalmos: a thickened retinocoroidal complex, a smaller anterior chamber and a posterior chamber, presence of optic disc drusense, a narrow angle, and presence of optic pigmentary retinopathy along with the foveus chisis can be present. So this was an unusual case. A 56-year-old female who presented with a high hypermetropia with a vision of 624 in both the eyes. and a neovision of N6 with the normal presbyopic correction. Her IOP in the right eye was 28 millimeter mercury. She was already on 4 anti-glaucoma medications. In the left eye, on 1 anti-glaucoma medication, it was 14 millimeter mercury. On the slit lamp examination, her corneal diameter was almost normal, the horizontal corneal diameter. Anterior chamber width was shallow in both eyes. She had RAPD in the right eye, lens was clear, and there was PI in both eyes. These are the clinical photos. And on gonoscopy, there was 360-degree pass in the right eye and a 270-degree pass in the left eye. Coming to the fundus, in the right eye, she had, so we expected some optic disc drusen or something if she was a nanophthalmos case, but instead we noticed an optic disc pit which was more easily visible on a 3D, 90D examination. On getting an OCT done, there was an optic disc pit which was confirmed, and there was a serious collection of fluid in the macular area, which was correlating with the optic disc, with the fundus image. And also she had these pigmentary flecks which were present in the mid-periphery, and this was present in both eyes. Similarly, in the left eye also she had in the mid-peripheral area she had pigmentary flecks. But the left eye, there was no cupping, her optic disc was normal, although she did have some hemorrhages and hard exudates which were present, which were attributed actually to a hypertension and labeled as a macular BRVO. When we got the biometric parameters done, her axis length was very less. It was 16.78 in the left eye, in the right eye, and 16.56 in the left eye. Antechamber depth was also less in both the eyes. Lens thickness was almost normal but slightly higher. Similarly, the keratometry, white to white was similar to what we measured on the slit lamp. And genetic analysis was done on pedigree analysis. There was no history of consanguinity and no positive family history. It was a sporadic onset. A diagnosis of bilateral nanophthalmos with pigmentary retinopathy with the right optic disc pit associated with optic disc pit maculopathy and angle closure glaucoma was made. And the left eye was angle closure with the macular branch BRVO. Secondary to hypertension with the bilateral high hypermetropia and presbyopia. So she was advised to undergo glaucoma filtering surgery in her right eye. However, she declined. So AGMs were just stepped up. She was 1 or 2 AGMs were added, and in the left eye, anti-VEGF injection was planned. Coming to the discussion, microphthalmos is when there's an anterior axial length of 2 standard deviation less than the mean for age, and depending on the measurements of the anterior segment or posterior segment, it can be classified either as nanophthalmos, relative anterior microphthalmos, or posterior microphthalmos. Multiple case reports have noted a syndromic association of nanophthalmos with angle closure glaucoma with pigmentary retinal degeneration, along with additional findings of optic disc drusen and foveage crisis, and it has been noted to occur with mutations of the MFRP gene. However, in this case, we noted an optic disc pit, which we believe is the first case to report such an association, as we could not find it in literature. Thank you.
What are your points, Prerna, to support the diagnosis of glaucoma? What the points? CDR I saw. What are the other
So the pressure
points?
was not controlled in the right eye on the maximal medical therapy, and there was an optic disc cupping the vessels which were exiting the optic nerve.
Fields were not possible in this patient because
Field, we could not do the fields. No, they might have been possible. The patient didn't come up. We had advised the fields, but
If the patient has both optic disc cup and he or she has also the pit, how we can differentiate between the two?
so we could see that the vessels were similar to when we see a 0.9 on near total cupping. They were exiting, but on the 90D examination, we could see that superiotemporal area there was a depression which was present, additional depression. And to confirm, we did the OCT, and on an OCT we could see an area of a pit which was there, along with the optic disc pit maculopathy, the accumulation of the fluid. So that's how the pit was diagnosed.
Most likely the pit is called recurrent CSR.
So, but there was an area of defect also in the optic nerve on the OCT. That's right.
next we have Dr. Indu Pavani Velamala. She is again speaking on malignant glaucomas. That's a hot topic for today. Malignant glaucoma, the problem after solution.
Once again, good evening. I'll be presenting second case, which is malignant glaucoma problem after solution. We have a 34-year-old female who is a resident of AIOS, Srikakulam. She came with complaints of diminution of vision in the right eye since 1 year, and she has no systemic comorbidities, no significant past medical and surgical history, and no family history of glaucoma. So on clinical examination, best corrected visual acuity in the right eye was 20/30 N6, left eye was 20/20 N6. The anterior chamber depth was shallow, that is peripheral anterior chamber depth was less than 1/4 of the corneal thickness, and she has grade 1 RAPD in the right eye. The lens was clear in both eyes, but intraocular pressure by Goldman ablation torometry was 50 millimeters of mercury in the right eye and 35 millimeters of mercury in the left eye. On fundus exam, undilated fundus examination showed medium sized disc with 0.9 cup disc ratio, and there is a significant disc pallor. In the left eye is medium sized disc with 0.3 cup disc ratio. So gonioscopy in the right eye showed closed angles which were not opening on indentation, and the left eye showed occludable angles opening up to scleral spill with few goniocynic. So diagnosis of both eyes primary angle closure glaucoma with left eye primary angle closure was made, and she underwent both eyes NDAC peripheral iridotomy. This is the fundus picture which was seen 1 week later post peripheral iridotomy, and you can see that the right eye there is a diffuse pallor with inferior thinning, and the left eye was healthy with 0.3 cup disc ratio. So Humphrey visual field in the right eye showed biarcuate scotoma which was repeatable on 10-2 inferiorly. So she was started on travoprost and brimonidine and timolol combination and dorzolamide eye drops. Still IOP was 35 in the right eye and left eye was 20 millimeters of mercury. So pilocarpine was added in the right eye, and she was asked to review in 2 weeks. Later again IOP was 30 millimeters of mercury in the right eye and 19 millimeters of mercury in the left eye with maximum medical therapy, and she was planned for right eye trabeculectomy with mitomycin C. So surgery was uneventful, and the post-op day 1 intraocular pressure was 14 millimeters of mercury with formed anterior chamber. So she was started in routine post-operative management with topical steroids, cycloplegics like homide was started, and antibiotics were given. So, but she came to emergency on a post-op day 18 with this picture where she has a flat anterior chamber both centrally and peripherally, and when UBM was done there was a flat anterior chamber with anterior rotated ciliary process, and intraocular pressure was 32 millimeters of mercury, and at this stage she was started on atropine eye drops and itropolase eye drops which is topicamide with phenylephrine combination, and she was started on aqueous suppressant which is brimonidine with temolol combination. This is the bleb picture which you can see. Bleb is relatively low lying bleb, and at this stage right eye malignant glaucoma, aqueous misdirection, status post trabeculectomy for primary angle closure glaucoma, and left eye primary angle closure was made, and she was started on conservative as said before, and left eye was continued on the AGM. And but later on after 2-3 weeks also AC was still flat, and she developed early cataracted changes and the corneal edema due to lens corneal touch, and the vision has also dropped significantly to 20/250. At this stage she was planned for right eye phacoemulsification with intraocular lens implantation along with pars plana vitrectomy. In the intraoperatively pars plana vitrectomy was performed first, then AC has become better, then phaco with intraocular lens implantation was done, and along with the posterior capsular opening, so to prevent the recurrence of again aqueous misdirection. On post-op day 1, best corrected visual acuity was hand movements, AC was deep, more than 1 corneal thickness, and intraocular pressure was 26 millimeters of mercury. So she was again started on 2 anti-glaucoma medications. At 5 weeks post-op, the cornea became clear and vision improved to 20/30, and intraocular pressure was controlled on 1 anti-glaucoma medication. So malignant glaucoma remains one of the most challenging complications of ocular surgery. It is the most commonly encountered after glaucoma surgery in eyes with prior chronic angle closure, and ultrasound biomicroscopy aids in both diagnosis and monitoring the therapeutic response in eyes with malignant glaucoma. And the first line agents include mydriatic cycloplegic agents and aqueous suppressants. Surgical management includes pars plana vitrectomy with surgical removal of the anterior hyaloid face. In phakic patients, lens extraction should be considered when the anterior chamber did not deepen intraoperatively and with prominent corneal edema from lens corneal apposition, or when dense cataracts are present at the time of the surgery. So patients with diagnosis of malignant glaucoma in the affected eye have an increased risk of malignant glaucoma in the fellow eye whenever it is planned for incisional surgery. So iridozonular hyaloid vitrectomy should be done along with incisional surgery if it is needed in the fellow eye to prevent the same complication. Thank you.
Thank you very much. Excellent presentation. We have discussed, I think, malignant glaucoma. Thank you very much. We will go for the next presentation by Dr. Lippi, a case of aqueous misdirection syndrome.
Yeah, so much has already been talked on, and it's almost 6. I think most of you want to go and see the beaches. So I will be quickly covering this. Case of aqueous misdirection syndrome, no financial disclosures, brief introduction. We hardly need this now. AMS or aqueous misdirection syndrome is a relatively uncommon cause of secondary angle closure glaucoma that occurs due to postulated anterior rotation of the ciliary body. Clinically, it presents as axial shallowing of the anterior chamber despite a patent PI with elevated IOP. Initial management is medical and atropine. In addition to medical treatment, NDR, laser hyalotomy and capsulotomy are laser interventions. Surgical management is indicated in the event of failure of all these modalities. So case report, first presentation of a case, 68-year-old male who underwent uneventful bilateral small incision cataract surgery in the year 2020, presented with pain and DOV unilaterally in left eye in the year 2022. So after 2 years of cataract surgery, he presented with these features of malignant glaucoma, corneal edema, shallow anterior chamber, elevated IOP were noted. That was 42 to 44 millimeter of mercury. Pre-op axial length was almost normal in both eyes with intraocular lens implanted of plus 24 diopter. Left eye was treated medically with atropine and there's 3 glasses of AGMs. Within 1 week, IOP normalized and the chamber deepened. Corrected vision was 6/9. Fundus examination showed normal finding. At this time, patient was kept on one IOP lowering agent and atropine to mitigate against potential future IOP spikes. I don't have pics of the first presentation. The second presentation, patient returned after 1 year in February 2023 with similar picture. He had stopped using all medications for 7 to 8 months. I'm in a government college, so patients usually do this. They don't come for follow-up also until they have a problem. Aqueous suppressants and topical atropine with oral acetazolamide, they relieved the symptoms partially. Patient was advised retinal surgery. Patient refused this. And so on relative clearing of corneal edema, laser PI was done. After 3 days, posterior capsulotomy and anterior hyalotomy was undertaken. Transpupillary NDR vitriolysis was performed to semi-dilated pupil. Aim of treatment was to perforate the hyaloid membrane and to allow the aqueous believed to be trapped in the vitreous to flow into the anterior chamber. This is the picture post NDR capsulotomy and hyalotomy. We see a laser PI also in the pic. So after 1 week, vision in left eye was 6/9 with the spectacles. That's corrected vision was 6/9 and IOP almost normalized. Presently, patient is on single topical AGM and atropine since past 6 months. I believe to continue atropine for a long period or even lifelong. He reports no major symptoms on his last follow-up in August 2023. So this is a 6-month follow-up. So here is reported a case of aqueous misdirection syndrome that occurred unilaterally in a pseudophakic patient with no history of glaucoma or pseudoexfoliation, with 2 years delay time from cataract surgery. Anterior hyalotomy and capsulotomy along with medical treatment proved to be an option for the patient. These are my references. So when I was at Arvind Eye Hospital, actually as a fellow, I had not seen many cases responding to this capsulohyalotomy, and ultimately because retina department, it was just next to us, so we sent most of our cases for retinal surgery. So this is a case which I thought I should note, take pics and present it. But that is well known, as Vanita madam and sir has already told, anterior capsulotomy, hyalotomy is being done.
So technically this is a pure glaucoma department case.
No, I would like to highlight the fact that when a patient presents with what looks like aqueous misdirection, then one should make an attempt to do a PI because we don't know whether this is actually pupillary block or not. Simply because the diagnosis of aqueous misdirection cannot happen if there is no PI.
Right.
So the diagnosis of aqueous misdirection says that in the presence of patent PI, AC is shallow and IOP is raised.
Right.
So that I think is a very good point that you brought up.
Thank you.
Thank you very much. The next presenter is Dr. Malleshwari. She's going to present on tackling of choroidals because of ectopic uveal tissue.
Good evening. Thank you one and all for giving me this opportunity. So choroidals is a nightmare for every glaucoma surgeon. So I am going to present a rare case of choroidals with ectopic uveal tissue. This 50-year-old male came to us in Jan 2022. PA was done outside 2 weeks back. Baseline pressures for right eye 40 and left eye 58. And with 4 medications, 4 AGM, left eye pressure 32 and right eye 22. So one of our consultant added bemutaprost in left eye And after 3 weeks, again the pressure in left eye was 22 with 0.8 cupping and superior NRR loss. But the thing is, he developed acute allergy for the anti-glaucoma medication. So trap was planned and done on 7/2/2023. Surgery was uneventful. 10 days post-op period, the pressure was 22 in left eye, and after massage it is coming down to 10. After 3 weeks, again the pressure was 30 with massage 8, and so argon laser suture lysis was done. After suture lysis, the pressure was 12. So after 2 weeks of argon laser suture lysis, suddenly the patient presented with some decrease of vision in left eye. So AC was shallow and the vision was 612 and IOP 6 millimeters of mercury. So they tried various combinations of oral and systemic steroids for 6 weeks, and as there was no improvement in choroidals, so this patient is referred to me at this point of time. So I thought already 6 weeks they tried some other medications and all. So I thought wound exploration and flap repair is the best thing to do for this patient. So I went inside and this is the video. So this is the preoperative. So those are the choroidals and B-scan. And so when I tried to open the bleb area, the total conjunctiva was scarred. So I tried to open the conjunctiva without having any buttonhole. Surprisingly, I found a small tenon cyst over here and some brownish pigmentation ring kind of thing inside. So I tried to release the adhesions on surrounding this area, this arrow area, and those adhesions removed. And when I opened the tenon cyst, I found a brownish pigmented tissue in that one. So that was the ectopic uveal tissue. So that is causing scarring and tenting up of the scleral flap, which is causing leaky trab, and it's not leaking outside, but it is causing tenting up of the scleral flap and choroidals. So I tried to open, is there any necrosis or any other thing? Nothing was there. So I tried to form the AC with the visco, and I want to find out whether any other ectopic tissue is there or not. So at other point of here also there is some ectopic tissue away from the bleb also. So here also some ectopic tissue is there. So I try to suture the scleral flap. So nearly 9 sutures I kept to the scleral flap. So wherever leak is there, I try to seal that off. And again tamponade is applied with the help of scleral patch graft. So two anchoring sutures were applied onto the scleral patch graft, and then conjunctiva is closed. Finally, the bleb is formed nicely. So I try to close the conjunctiva with the help of vicryl sutures. So bleb is raised nicely and AC formed tightly. So at 1 day post-operative period, AC became deep and the choroidals were 90% dissolved, and these are the preoperative B-scan choroidals, and this is first day, and the second picture is the 1 week post-operatively. So this is the HFA of the patient post-operatively at 1 month, and the day 1 itself choroidals were resolved and the vision is regained back to 6/9. Until now the patient is maintaining vision as well as he is not using any AGM. As I searched for the literature, there is nothing mentioned in the literature where the choroidal tissue causing the tenting up of the scleral flap. So that I found it's a rare situation. That's why I just want to present this case. Thank you for giving me this opportunity.
Madam, was this not a deep flap taken, means the incision which was taken? This was done by somewhere else, this was done?
No, in my hospital only, some other surgeon done that.
So don't you feel that this flap that went deeper and because of that?
No, it's okay. Flap was very much nice. It was the ring of ectopic tissue which was present there. It is really causing that pull over the scleral flap.
Okay.
So I just removed that area and I kept nearly 3 sutures in that area, so that it became flat, and I gave tamponade with the help of scleral flap.
Query once in the primary surgery, one of the flap for the sector was not seen at that point of time.
Sir?
At the time of the primary surgery.
I am not the primary surgeon, sir, so I don't know whether that's why if any vascular tissue is there.
It would have been ectopic, then it would have been present at the primary surgery also.
Yes, sir. Maybe that's what, sir. Even
it
if
was a referred case,
It was done in my hospital only, but I was not the primary surgeon.
No, in your hospital, but not the laboratory.
Not referred.
But then you could have asked the primary
Yes, sir,
surgeon.
but they were maybe after 6 weeks or 1 month they couldn't remember the case properly, sir. But other place also some ectopic tissue was there, so I thought this must be the. So I searched some other areas also. Little bit of ectopic tissue was there, but I couldn't keep it in that video because it was out focused while taking the video.
What's your opinion about it?
Very unusual case. I have not faced it.
Yes, ma'am. In literature also nothing was found.
Management has worked. And that is what matters at the end of the day.
So we have the next and last presentation
Thank you.
by Tiruvidi Sai. Yes, Yeshwant. Juvenile open angle glaucoma in oculodentodigital dysplasia.
Yeah, good evening everyone. So never miss juvenile open angle glaucoma in Meyer-Schwickerath-Weir syndrome. So coming to the case, it's a 12-year-old girl from Andhra Pradesh visited my hospital at 2023, presented with complaint of left eye diminution of vision since 6 months. So associated with mild pain and redness occasionally. There was no any history of trauma or medication usage, and a history of consultation 3 weeks before at local hospital, and they started both eyes to AGMs, and baseline IOP was not known, and old records they have not brought at that time. So when coming to the ocular examination, patient vision in the right eye was 20/20, and eyelids are normal, cornea is clear, but horizontal corneal diameter was 9 mm. Anterior chamber was normal in depth, iris is normal in pattern, pupil and lens are round regular, and clear lens was seen. And when coming to the left eye, the unaided visual acuity was 2200, and it's not improving. And horizontal corneal diameter is 9.2 mm only, and the anterior chamber was normal in depth, and iris is normal in pattern. Pupil is round regular reacting, and lens is clear. And intraocular pressure with 2 AGMs in the right eye was 15 millimeter of mercury in both eyes, and the central corneal thickness was 560 and 565 microns. On gonioscopy, there was a open angles, and fundus in the right eye was 0.3 cup disc ratio, but in the left eye it was a near total cupping was there, and axial length was 21.4 mm and 22.92 mm. So on general examination, so coming to the systemic features, I have found a small nose with a pronounced nasal bridge noted, dysplastic teeth, dental enamel hypoplasia, and thickened jaw was there. Both hands showed shortening of metacarpals and of 4th digit as compared to the 2nd and 3rd digits, and the syndactyl of 4th and 5th digit was seen. So I came to a diagnosis of both a juvenile angle, open angle glaucoma with microcornea in a Meyer-Schwickerath-Weir syndrome, which is also known as a oculodentodigital syndrome. So she was referred to the pediatric neurologist and cardiologist to rule out any structural anomalies in the brain and cardiac arrhythmias respectively. After 1 year IOP was uncontrolled in the left eye with maximal medical therapy, so trabeculectomy was done, and AGMs was continued in the right eye as patient can last to follow up also. So IOP was maintained with 10 plus or minus 2 millimeter of mercury during the follow-ups. So my main conclusion is that despite small corneal diameters, development of glaucoma or juvenile open angle glaucoma needs to be ruled out, and if present should be treated early in patients with oculodentodigital dysplasia, and these patients should be treated in multidisciplinary approach in cooperation with a pediatric neurologist, cardiologist, orthopedician and dentist, and follow-up should include a complete eye neurological, hearing and dental evaluation. So some studies have shown that they have some patients have a history of seizures was there, cardiac arrhythmias are there. So for that purpose I am presenting mainly. There should be a multidisciplinary approach for this type of patients. Thank you.
Thanks for educating us. Any questions? Okay, so I hand it over to our chairperson, sir and madam.
So it is a very good session of glaucoma we had at this conference. I thank you all for making the valuable scientific inputs, presentations. Let's disperse and enjoy the rest of the day.